Our next speaker is Andrew Lotery, speaking on the VICI study of Eplerenone for central serous retinopathy.
Thank you. It's my pleasure to present the results of the VICI study of Eplerenone for central serous chorioretinopathy. These are my financial disclosures, none of which pertain to this presentation. I'd like to acknowledge the contributions of the writing committee and co-investigators to this study, and particularly Professor Shobhas Sivaprasad, who was the co-lead for the study, along with the Clinical Trials Unit in Bristol and the funder, which was the National Institute for Health Research. The aim of the VICI trial was to compare the efficacy and safety of Eplerenone with usual care versus placebo with usual care for chronic central serous chorioretinopathy, CSCR, for 12 months in a phase 3 randomized placebo-controlled clinical trial. The definition of chronic CSCR in this study was visual impairment due to CSCR of greater or equal to 4 months duration, defined as subfoveal presence of subretinal fluid on OCT scans, characteristic appearance of CSCR in fluorescein and indocyanine green angiography, and the investigator believed that there was sufficient evidence from the patient history, case note documentation, or appearance of the macula that CSCR had been present for at least 4 months. The primary objective in eyes with chronic CSCR was to evaluate whether Eplerenone therapy is superior to placebo with respect to best corrected visual acuity. Trial design. This was a multi-center study in 22 UK sites, parallel in 2 groups. Patients were randomized 1-to-1, stratified by site and high and low best corrected visual acuity. It was placebo-controlled, with masked healthcare personnel, research personnel, and outcome assessors. The primary outcome was best corrected visual acuity at 12 months follow-up, adjusted for baseline. There was 1 study eye per patient. Intervention and comparator. The intervention was oral Eplerenone, 25 milligrams once a day for 1 week, increased to 50 milligrams once a day for up to 12 months. The comparator or placebo was oral lactose-filled capsules, also given once a day, and identical appearance to the intervention Eplerenone for up to 12 months. Treatment was withdrawn if serum potassium was greater than 5 millimoles per liter at any follow-up time point. However, participants who were withdrawn from treatment were invited to continue follow-up to 12 months. Sample size justification. We calculated that we needed 45 patients in each of the 2 groups, and this was sufficient to detect a clinically significant difference of greater or equal to 5 letters in best corrected visual acuity with 90% power and 5% significance. The total number of participants was increased to 104 to allow for up to 15% dropout over 12 months, but we actually over-recruited to a total of 114 participants. These are the baseline characteristics for age, gender, ethnicity, and fluorescein angiography phenotype between the placebo and Eplerenone groups, and they were balanced between the groups. This is a consort diagram showing the flow of patients through the study. So after initial safety visits, particularly looking at potassium levels at 1 and 4 weeks, patients were seen every 3 months through to 12 months. There was excellent follow-up with few dropouts, just 7%, and adherence as judged by pill counts was greater than 80% at all times. Safety summary. Somewhat surprisingly, there was an equal number of 8 participants in both the placebo and the Eplerenone groups with a potassium of greater than 5 millimoles per liter. In retrospect, the potassium threshold for cessation was conservative. There were no suspected unexpected serious adverse reactions and very few serious adverse events, 3 in total, all unrelated and none in the Eplerenone group. The time to resolution of subretinal fluid. There was complete or partial resolution of subretinal fluid in 70.4% of the placebo group and 66.7% in the Eplerenone group. The time to complete or partial resolution of subretinal fluid was not statistically significant between the placebo or Eplerenone group. The primary outcome was best corrected visual acuity. And this graph shows the visual acuity at each of the time points in which it was measured, with placebo in blue and eplerenone with dashed red line. The data is expressed as the median and interquartile range instead of mean and standard deviation, as the data are skewed. The median is the middle number in a sequence of numbers. There was a mean difference of 1.54 letters read, favoring the eplerenone group. However, this difference is not statistically significant. These are the effect size for the best corrected visual acuity, low luminance visual acuity, and VFQ-25 composite score. If a bar crosses the 0 line, there is no significant difference. So you can see that there was no significant difference for the primary outcome of best corrected visual acuity, low luminance visual acuity, or the VFQ-25 composite score between placebo and the eplerenone groups. So in summary, the trial has produced very clear, unequivocal findings. Eplerenone is not better than placebo for treating CSCR. The trial ran very successfully to a high-quality standard. The quality of the trial and the clarity of the findings mean that the trial should definitely change practice. Eplerenone should not be used to treat CSCR. Attention of ophthalmologists and research can now be directed to alternative interventions. Many thanks for the commitment of the participants and research teams. Thank you.